Hello everyone, I am Dr. Pranavananda Pal. I am a medicine PhD working in SSKM Hospital. I am here to tell you the COVID ward duty simplified guideline, specially targeted for junior doctors. So, guys, we are working together in a middle of a pandemic, and we are showing enormous strength and perseverance by following our duty with wearing PPE for hours within this extreme pressure of patients. It's high time that we should care about our health and our family members as well. Also, we need a simplified guideline to treat a lot of number of patients who have similar clinical profile. Government of West Bengal and AIMS both have published their own guidelines regarding the management of patients. I have just simplified those guidelines, and I have described in this video. So, first of all, I would like to tell you everyone that uh, we should all we should all start wearing PPE, because PPE is the only thing that can save us from the virus, and we should protect ourselves to protect others. That we should not make ourselves sick, because it's a part of our duty that we have to keep ourselves well. So, going to the guideline directly. So, when a new patient of COVID gets admitted, we should we should first check the vitals. The most important vitals are pulse, BP, SpO2, respiratory rate, and CVG. So, in the wearing PPE, we cannot we cannot examine the patient properly. We cannot listen to his chest, and we cannot measure manual BP. So, in this situation, the digital machines are our only. So we should look for comorbidities. Like, important comorbidities are diabetic, hypertension, cancer, heart disease, liver disease, and chronic kidney disease, or any transplant. So vitals tell a lot about the diagnosis, because with the vitals we have to classify the patient and triage the patient. Which patient needs more aggressive treatment, which patient maybe treatment may be delayed for a minute or two. It can be diagnosed by checking the vitals. Secondly, the comorbidities will tell you how severe the disease may be, because a diabetic patient will definitely have high risk of developing severe disease than a non-diabetic patient. So and also regarding the medications, the hypertensive and patients with heart disease, they are already on some medication. Whether should continue the medicines or not, we shall discuss in the video. So we have to divide the patient according to the vitals: pulse pp, SpO2, respiratory rate, and CVG. We have to divide it according to the patient, according to the severity of the disease. First of all, mild disease will have pneumonia, features of pneumonia like cough, fever, diarrhea, and respiratory distress, along with any weakness. Along with any one of them should be considered as a symptom of COVID, and one should not delay the diagnosis of COVID by hesitating that only one symptom is there. Whether should I take this as significant or not? If at the time of pandemic, even one symptom is very significant. So if the patient having symptoms of pneumonia along with SpO2 more than 95% at room air, with respiratory rate less than 24 per minute, that means the patient is mild disease. So these are the ideal candidate of the home isolation. So we should consider them, the patient should for home isolation. If However, even in the mild case, if the patient is having some red flag signs like raised CRP, raised D dimer, and raised neutrophil lymphocyte ratio in CBC, we should admit the patient in COVID ward. So it's important that we must find out the red flag sign positive patients among the mild case. Otherwise, the mild case can be managed the mild case can be managed at the home isolation itself, consequently some medicines. So next, the most cases we will be facing in COVID ward are the moderate cases. Moderate cases are those having pneumonia along with SpO2 being 95% or less at the room air, and respiratory rate more than 24 per minute, meaning the patient having respiratory distress, and his O2 requirement should be less than 15 liter per minute in COVID ward. So you should admit the moderate cases in COVID ward, and those having less than 15 liter per minute, they are considered as moderate cases. If the patient is having oxygen requirement more than 15 liter per minute, the patient should be shifted to intensive care unit like HDU and CCU, and they should be treated there. But you should admit the moderate cases which having less than 15 liter per minute oxygen requirement. You should admit in COVID ward, and you should look into the red flag sign in moderate cases as well, because in this patient having red flag signs in the moderate cases which are having red flag signs, they should be also transferred to the intensive care unit. So you can see that the red flag signs in moderate cases are features of shock like SBP less than 100, and altered sensorium, sepsis, multi-organ dysfunction, increasing oxygen demand, and respiratory failure, PO2 by FiO2, PO2 by FiO2 less than 200. So these are the features of red flag signs in moderate cases, and they should also shift to HDU, and their management is different. So the patient who are admitted in COVID ward, they should be treated with a common consensus that in the time of pandemic, the individual treatment is less beneficial, and you should give them the optimum treatment. So first of all, you should all the patient admitted in COVID ward should be counseled about prone ventilation. Prone ventilation is a very important thing in COVID scenario, because it has been seen that the prone ventilation improves the oxygenation status of the lung, and it improves the alveolar oxygenation, and improves the saturation, and decreases the O2 requirement. So every patient, when they are being admitted in COVID ward, you should counsel them for prone ventilation, because it is very important, and they should be following it most of the times during the daytime and also night also. At least 22 hours per day they should be kept in prone ventilation. So you should counsel them for prone ventilation. If the patient can take orally, you should prescribe oral medication. Only if the patient has altered sensorium, then you should consider about IV medication, or the patient cannot take fluid orally, then you should consider IV fluid. But if the patient can take food orally, you should consider oral medication. So the sole purpose of admitting the patient in COVID ward is to a central oxygen line which provides moist oxygen inhalation. So it's very important, and oxygen is a drug. It's a drug. So it has a dose, it has a duration, and overdosing and underdosing will cause harm to the patient. If you cannot give more oxygen to the patient, it will cause lung fibrosis. You cannot underdose the patient with oxygen, because it will not meet his oxygenation status, and he will deteriorate. So you should know what are the methods of giving oxygen. Like, first of all, if the patient's oxygen demand is low, you should always consider nasal cannula. It supplies oxygen. You can see nasal cannula. It supplies oxygen at 3 to 5 liter per minute. If the patient is maintaining more than 95% saturation in this nasal cannula, you should keep the patient in nasal cannula itself. No need to up-titrate the oxygen. If you feel that the oxygen, if you see that patient is not maintaining oxygen SpO2 more than 95% with this nasal cannula, you should then shift the patient to oxygen mask. Here you can see oxygen mask. It supplies oxygen through 5 to 10 liter per minute, and if the patient even then the patient cannot maintain his oxygen status more than 95%, then you should consider shifting the patient to NRBM mask. It supplies oxygen through at 10 to 15 liter per minute. You can see this bag, this is this extra oxygen reservoir, and improves the oxygenation status. So it's important to find out that not only having the oxygen source is important, the delivery system is also important. delivery system, it's called delivery system of oxygen. It's also important because people are gathering oxygen cylinders in their home, not knowing that whether they should provide oxygen via nasal cannula or oxygen mask or NRV mask. It's important that everyone the oxygen should be given it and proper dose via proper delivery system, because if you give 10 liter per minute oxygen via nasal cannula, it will not benefit the patient. If you give the delivery system is also very important. Next, in the initial days of my initial cases or mild cases, you should give the medications which have been suggested by the guidelines, like tablet doxycycline, antibiotic, and tablet ivermectin, and paracetamol, vitamin C, paracetamol for fever. If the fever, even if the fever doesn't come every day, you should give you may give it for headache and body ache also. It will improve it. And vitamin C and zinc for improvement of immune status, and levocetirizine or cetirizine for cough, and ambroxol syrup for dry cough, and pantoprazole for ulcer protection. Okay, so next there is a paradigm shift in the COVID management. In last few days, both AIMS guideline and West Bengal guideline have included an important thing in the guideline, that is the MDI budesonide. So where will you give it? The dose is, the indication is the cough predominant symptom, or there is progressive cough after 5 days. So you should consider MDI meter dose inhaler budesonide. The dose has been varied in West Bengal guideline and AIMS guideline. The common consensus is 400 mcg 2 puff BD for 5 to 10 days. And if the patient was already getting steroid inhaler for his COPD or asthma, you should continue it. Okay, so this is the new inclusion in local steroid therapy, and it has been shown to improve the cough symptoms of the patient. Now, systemic steroid, it's very important. It is also a paradigm shift in the treatment of COVID. To decrease the burden on hospitals, the guidelines have also included steroid even if in the home isolation patients, if the patient is having high grade fever or fever is reappearing after 5 days. The high grade fever after 5 days or reappearing fever, suppose the fever came for 1 to 2 days initially, then the fever did not come. After 5 days you are seeing that the fever is reappearing, the symptoms are getting worse, then you should always consider systemic steroid. How? And second indication is cough worsening or falling SpO2 after 5 days. So you should know the pathophysiology of this indication, because the initial fever of COVID is due to viremia, and it does not harm much, but when the fever is coming after 5 days, it is an early implication that the patient is going into cytokine storm. The reappearing fever indicates the raised inflammatory markers. You don't have to see IL-6, you don't have to say any inflammatory marker. The clinical symptoms is enough to know that the patient is going to cytokine storm, and then you should intervene with systemic steroid. It has been shown drastically improve the status of the patient, clinical status of the patient. How? The dose and drug is the tablet dexamethasone 12 mg OD for a 60 kg person. The dose is 0.1 to 0.2 kg for at least 5 to 10 days. The dose and duration is very important. If the patient can take orally, you should give tablet, and if the patient cannot take orally, you should give injection. The alternative the dexamethasone is the key to the COVID management. You have to give it in proper time, you have to give it in right duration and right dose. The alternative regimens are tablet prednisolone. You should always take a opinion of a qualified doctor for before administering the steroid, but uh, you should give steroid at time. The alternative regimen are tablet prednisolone or tablet prednisolone. Okay, you have to convert the doses. These are convert the doses. Suppose the patient dexamethasone 12 mg, the steroid in the steroid equivalent dose. So the dexamethasone 12 mg has steroid equivalent dose of methylprednisolone have 32 mg. Okay, now let's go to the LMWH, low molecular weight heparin. Prophylactic dose of low molecular heparin should be given all moderate cases and those having D-dimer more than 2 into upper normal limit. Prophylactic dose given because the COVID patient, it has been shown that there is evidence of pulmonary thrombosis which worsens the case, and the recommended dose is injection enoxaparin, which is a type of LMWH, 40 milligram subcutaneous OD. Okay, subcutaneous OD for 5 to 10 days. If the patient having any renal failure and the patient cannot, then the patient should not be given LMWH. They should be shifted to unfractionated heparin 5,000 international unit SCBD for 5 to 10 days. The duration of the LMWH or AFH should be directed by D-dimer value. According to D-dimer value, they should be directed. And contraindication of the this heparin is always active bleeding and deranged PT and INR. Alright. So next you should investigate some routine investigation. These are very important because based on this the treatment will be escalated or de-escalated. And routine investigation CBC to look for neutrophilic lymphocyte ratio, which is a important marker of severity. Next is CRP and D-dimer, LFT and urea creatine to rule out MODS, and RBS always if you are especially if on steroid, because steroid is going to impair his glycemic status, and you should always look into routine blood sugar. Okay, next is chest X-ray should be done in all cases, because chest X-ray will show any secondary pneumonia or any other lung changes due to COVID. And HSCT thorax should be done in resource limited hospital like ours in selected cases. And CT severity score should be a CT severity score can be calculated from the HSCT thorax, which can be a important clinical important marker of severity. Okay, next is important thing is you have to look after the comorbidity he is having. The pre-existing comorbidity should be adequately taken care of, because if the patient having diabetes mellitus, you should shift the patient to insulin. And especially if the if steroid is prescribed, check CBG TDS at least thrice daily, because if the patient is on steroid, his glycemic status is going to be disrupted. So you should check for glycemic status of the patient. And if the patient is having hypertension, you should continue the home treatment the patient was getting. And if BP falls or any features of shock is present, then you should consider stopping the medication. If the patient was having heart disease, continue all treatment including aspirin and statin and anti-anginal agents. If the patient was having COPD, continue his inhaler he was having. If the patient cannot take inhaler, you should shift to nebulization of the patient. If the patient is having liver disease, continue all treatment of the liver disease as before. Okay, now I will shift to the management of COVID. In the basic outline of COVID management in ICU setup, it's very important, because some of our family members may maybe shifted to ICU sometimes, or we are giving to patients, we are talking to many patients, they don't have any idea about the ICU management. So you should, all doctors should know basic thing about the COVID management in ICU setup. Okay, so the respiratory is, first of all, shifting the patient to ICU. uh, excuse me. The sole purpose of shifting the patient to ICU is number one is constant monitoring, and number two is respiratory support of the patient. Okay, if the patient cannot maintain his oxygen SpO2 more than 95% in ward at more 15 liter per minute, then you should consider providing him or her to high frequency nasal cannula. If it will decrease the work of breathing, because it supplies oxygen at 20 to 40 liter per minute. So it will 20 to 40 liter per minute in HFNC. So it will reduce his work of breathing, and it will improve the patient. If the patient then also cannot maintain his oxygen, you should consider him to shifting to non-invasive ventilation, or continuous positive air pressure ventilation. This with full air mask. Then you should it will also reduces the work of breathing. If then also the patient cannot tolerate NIV due to altered sensorium or any other comorbidity, then you should consider of intubation, because we all know that outcome of intubated patient with COVID is very poor, even in foreign studies and also in Indian studies also. So steroid is also most important in all cases of severe cases. Within when the patient is having cytokine storm, the recommended dose is double in cases of severe cases, 0.2 to 0.4 mg per kg dexamethasone, or steroid any other equivalent dose. Antibiotic should be given only in if sepsis suspected, like high total leukocyte count, raised procalcitonin, and worsening course. And broad spectrum antibiotics should be given like injection ceftriaxone, meropenem, or piperacin tazobactam in renal modified dose. So supportive management with continuing with IV fluid, and septic shock management as standard protocol with noradrenaline or dopamine or dobutamine. As so there is a lot of confusion regarding the remdesivir, the antiviral drug. There is a lot of black marketing and all, we all know that, we have all seen that, but we have to remember that remdesivir is important only within 10 days of symptom onset, when there is viremia in the patient, because after 10 days there is no viremia, and it's an antiviral drug. So remember, it's an antiviral drug, it kills the virus, and it has no role in the cytokine storm when the virus has gone from the body, but the cytokines are destroying his lungs. So at that phase remdesivir has no role. So there are some myth buster for you, because there is a lot of things, there are lot of people calling you for their what they have found in WhatsApp knowledge, for